Good evening, and thank you for tuning in to the ASGBI's Regional Journal Club. Today we're going to present a paper entitled The Use of Minimally Invasive Surgery in Emergency General Surgery Procedures. This is published in Surgical Endoscopy and was featured as Paper of the Month in September at the Emergency General Surgery Update of the Royal College. Surgical Endoscopy has an impact factor of 3.14. This article has been tweeted a lot in North America and in the UK. And has been cited in a paper in the Annals in May regarding emergency surgery during the COVID-19 pandemic. So the authors are based in Charlotte, NC in the US, and their rationale for doing this paper was that they felt there were guidelines for appendicitis and biliary disease in terms of minimally invasive surgery, but it was limited to that, and they didn't find that there were specific guidelines from the major associations with respect to minimally invasive surgery for adhesive bowel obstruction or peptic ulcer disease. So they aim to look at the trends of utilization in minimally invasive surgery, and also hypothesized that open cases have higher post-operative mortality, SSI, and length of stay. So what they did is they looked at the American College of Surgeons National Surgical Quality Improvement Database. It was retrospective, looking at cohorts of laparoscopic versus open for the operations, being appendicectomy, cholecystectomy, peptic ulcer, and bowel obstruction. So they entered ICD-10 queries for these 4 operations, and they only included procedures if they were defined as emergency, and they identified whether they were lap or open by looking at secondary codes, if codes such as diagnostic laparoscopy or laparotomy were added. So their outcomes were mortality, as well as secondary outcomes of SSI, and they looked at some additional outcomes that were general complications. So their results showed over a 10-year study period, they had 190,000 patients that they identified for these 4 operations. Appendicitis, there were 165,000. Gallbladder disease, about 10,000. Bowel obstruction, similar, about 2,400. Peptic ulcer disease. One thing to note is they had to exclude a lot of their peptic ulcer disease results, because only 366 of them were coded specifically as a lap or open. There wasn't any information about how this same process affected the other 3 operations. So the first thing they're looking at was the utilization of MIS over time, and for the 4 operations, it was statistically significant that there was an increase in uptake for MIS approach. And this graph just sort of supports that for each of the 4 operations. Now, this table is quite a busy table, but it looks at all of the complications for the complications for all 4 operations, and it shows that in the top group, cholecystectomy, MIS had reduced general major complications, reoperation and readmission, and length of stay, and it was statistically significant. And this same trend applies for appendicectomy, for bowel obstruction, although for reoperations, although reduced, it wasn't statistically significant in favor of the minimally invasive group. And in the peptic ulcer disease, major complications, reoperation, readmissions, they were not statistically significantly reduced in MIS. Then looking at the SSI rate, they also looked at subsets such as superficial, deep, or organ space SSI. And for cholecystectomy, appendicectomy, and bowel obstruction, for all these subsets, it favored laparoscopic approach, and this was statistically significant. For peptic ulcer disease, any SSI or deep SSIs and organ space SSIs, it looks like overall the numbers were less for laparoscopic, but this did not reach significance. In the organ space group, actually, it was more in the laparoscopic cases, but this again did not reach significance. They also did a multivariate analysis, and the information the paper gives is that the regression models they used were adjusted for diabetes, smoking, functional status, congestive heart failure, preoperative sepsis, and weight loss and wound class. And what this table is looking at is it's looking at the odds ratio of minimally invasive approaches versus open for death, for SSI, for length of stay. And they were all less in favor of minimally invasive. And the numbers that are bold, which is almost all of them, signify that these were statistically significant. The only procedure and only complication that these were not statistically significant for was the SSI rate in peptic ulcer disease. This was less in favor of minimally invasive, but not statistically significant. So the authors concluded that there were statistically significant improvements in SSI, length of stay, and 30-day mortality in favor of minimally invasive procedures. And when controlling for patient and disease characteristics, again, it favored minimally invasive procedures for all procedure groups. So having a look at this paper, first of all, there were probably a number of biases using a registry. It would favor hospitals that were astute enough to submit their cases to a database. It only included procedures defined as an emergency. This may have missed a lot of cases, in my opinion. I think some operations such as perf ulcer or appendix is a given that it's an emergency, and the theatre staff may not have additionally coded them as emergency. So cases may have been missed like that. And again, they only managed to identify cases as lap or open by looking at a secondary code. And this secondary code may have not been put in for many cases. And actually, that's what happened to their peptic ulcer group. They had to exclude almost about 2,000 peptic ulcer cases because of that. And this may have been why a lot of their the peptic ulcer cases, especially looking at SSIs, may not reach significance. Other biases, selection of the actual cases, so contaminated or very sick cases may have automatically gone for open, and more physiological stable patients may have been selected for minimally invasive. So there has been shown to be an increased use of minimally invasive surgery in this data set, and I think that was expected. An appendicectomy and cholecystectomy are already established as minimally invasive procedures. So what's most interesting is establishing emergency surgery for bowel obstruction and peptic ulcer as minimally invasive. So let's look at the bowel obstruction group. So there were promising results, less SSI in all of the subsets for the bowel obstruction group. There wasn't any breakdown for the bowel obstruction group in terms of Hartmann's procedures, band adhesions, hernias, widespread adhesions, because there would be a different approach to each of these subsets, and it would be very interesting to see that broken down. Perforated, more contaminated cases probably would have gone straight to open, and the paper didn't give us a conversion rate of converting from lap to open. When we tried to put it in the context of UK data, there was a audit, the NASBO audit on small bowel obstruction in 2017. And they stated that almost half of their small bowel obstruction cases went to surgery, 48% had emergency surgery. And out of those, 1 in 7 had an attempt at keyhole. And out of those 1 in 7, about half of them needed to convert to open to actually carry on. So that shows that there has been uptake of minimally invasive surgery for small bowel obstruction in the UK. Now the peptic ulcer group, so they had 0% minimally invasive approach in 2007 and 37% in 2016. So that shows in a 10-year period quite a lot of increase in MIS approach for these cases, and they're promising results. Less SSI in most of the categories and reduced length of stay. Again, they didn't show a conversion rate if they converted from lap to open. And it'd be interesting to have the UK data for this. And I wonder if this could be looked at from the NELA database. And I'd be interested to see what Hannah, the NELA fellow, has to say, and if she had any comments about this actually. Just for interest, this is RCT from 2002, published in the Annals of Surgery, of a study done between 94 and 97. favouring MIS in terms of post-op pain and length of stay and return to work time. So it was interesting. There was, RCT 2002, and in 2006 there was still 0% uptake in minimally invasive surgery. So it shows that sort of how long it takes actually sometimes for practice to be established. And this is a review, a really comprehensive review this year of minimally invasive surgery, peptic ulcer disease, which advocates for it, particularly in young patients, but says there is certainly a scarcity in data, particularly for patients over 70 years old and ASA3. So to conclude, this is a large national registry. There was some potential for selection bias, but it's a large number of cases. We can't ignore this data. There were promising results in favor of MIS, and it needs to be a consideration for selection in MIS cases. And more data on actually how MIS cases were selected would be really interesting to see, especially in high frailty populations. So to conclude, there is potential for more MIS in emergency surgery cases, and especially in the context of trying to reduce length of stay, especially during the pandemic. But conversely, this could mean longer operations, and is now the right time to be considering MIS and EGS procedures in light of COVID-19. Thoughts are actually, should there be more EGS training and MIS procedures, or should there be an increase in the subspecialty EGS rota? So points that'd be really interesting to see discussed in the Twitter chat after this presentation is, does this paper pose an important question? What were the biases? How does this present reliable data? And is this data and the data and the literature out there enough to push for MIS EGS cases? And is it realistic in your current centres to increase MIS EGS cases such as bowel obstruction or perforated peptic ulcer surgery? And I'd be interested to see what the leading MIS surgeons in the region say about their vision for training and delivery of MIS in EGS. So thank you for listening, and look forward to the Twitter chat after this presentation. Next month's presentation will be 24th of November at 7 p.m. by Jazz Sierra. Thank you very much.